I'm Dick Moberg, and for more than 40 years I've been developing technology to advance our understanding of the injured brain. I've had a chance to work with some of the leading minds in the field of neuromonitoring, including physicians, researchers, and entrepreneurs. I want to share their stories with you in the form of a weekly podcast so you can stay current on the latest developments in the field and the innovative people behind them. This is my neural network. A quick note before we get started. I caught up with Dr. Hemphill at the ICP 2019 meeting in Leuven, Belgium during one of the coffee breaks. There's a bit more background noise than we anticipated. Dr. Hemphill had some great things to say, so we decided to publish it anyway. We appreciate your patience and hope you enjoy the episode. This is Dick Moberg, and my guest today is Dr. Claude Hemphill, who is a professor of neurology at UCSF and the Division Director at Zuckerberg San Francisco General Hospital. So, Claude, thanks for being with us today.
Well, thanks for having me, Dick.
And today's topic is on the trials and tribulations of setting up a multimodal monitoring program, which Claude has gone through. But first, I wanted to let everybody know that Claude is one of the founders of the Neurocritical Care Society. So way back, I remember I was at the first meeting, but he was actually at the founding meeting. So how did that happen?
Well, a number of us were at the American Academy of Neurology Emergency Neurology and Critical Care section meeting, and we were very interested in seeing if the American Academy of Neurology would support what we were doing, because we thought that was a great home for the potential new growing field of neurocritical care, and they didn't. They didn't want to provide any money. We were told that the president of the AAN at the time felt like it really wasn't an area that had any legs and wasn't something that made much sense. And we were really unhappy. So we went out for drinks and a steak dinner, and we pledged to create a neurocritical care type society. And we wrote our pledge on a napkin, and Bill Copeland put it away somewhere. And 2 years later, he pulled it out and said, "Remember, we pledged to do this," and sort of the rest is history.
And it's a great history. I mean, that society has just taken off. And I remember being at the first sort of formation meeting. That was in Phoenix, I think, right after that. Been going ever since. But that's a great story and a great start to a great society. So you just sort of went through a interesting process of getting multimodal monitoring established at San Francisco General. And what were your experiences? I guess what were your expectations with that? And I know you're quite a data pioneer in neurocritical care. Some of the first papers published on that, I think, came from you. And so what were your expectations?
Well, I think there really are two parts to it. One is multimodal monitoring itself. And we've actually been doing multimodal monitoring for a very, very long time. My colleague, friend, and partner, Jeff Manley, and I believe we're the second folks in the United States to do brain tissue oxygen monitoring. We actually got an IDE waiver to do it in a research context. Around 2000, or maybe a little bit before that, we got advice from Claudia Robertson, who was the first to do that. And since then, we've integrated that clinically into our care, as well as jugular venous saturation monitoring, microdialysis for a time, cerebral blood flow monitoring, EEG, and so forth. So we've had multiple modalities, but the big deal has been integrating the data and really having a platform that is clinician-facing so that we could have not just us, but our bedside nurses and our other neurocritical care and neurosurgical physicians and our intensivist colleagues see the data and use the data. And that's really what we've been doing in our new Zuckerberg San Francisco General Hospital, where we were fortunate through a philanthropic investment and sort of interest in sweat equity to have Moberg units placed in all of our neurocritical care beds. And it's really been an interesting process, because I think creating a distributed system that allows us to be able to look at the data both at the individual bedside and then remotely, it's not a trivial task. And I think that we've had to get a lot of buy-in, which has ultimately been very fruitful from our IT folks. And we've had an IT champion. His name's Greg Wolfer. I'm going to just say right out that Greg is fantastic. And he's really been the lead from the IT side. And we've also had been able to have a system manager who is a nurse educator named Lawrence Child. And Lawrence really serves as our system manager. And honestly, those two positions, and those aren't full-time positions at all, but they're part of their overall work and responsibility, have really been key in helping us out with that. And now, Dick and I are here at the ICP 2019 meeting, and while he was presenting on his system, I was looking up a patient on my laptop. The meeting's in Leuven, Belgium, not in San Francisco. So that's great, and so I think it's going well now.
That's great, and we've enjoyed working with you, and I think I can't emphasize more about the team you need to get in place ahead of time. We've had successes, and we've had challenges at institutions that didn't have somebody like Greg or Lawrence there. And why don't you talk a little about just the nurses' adoption? I know that in most places it comes as a sort of a new thing for them, and sometimes they can present some challenges, but you seem to have navigated that fairly well. How did that go?
Well, there are some systems that gather the data and port it out to a data archive where clinician researchers who are doing research or quality assurance can then access the data. But clinicians at the bedside don't see it. Therefore, it's invisible to them, and they may not even know it's being gathered. We had such a system up at the UCSF Medical Center. Folks didn't even realize they had it. We consciously chose to implement a informatics system that was clinician-facing because we thought it was important if we were going to use the information for patient care that everybody needed to use the patient information for patient care. But it's very, very key that you use the information, because if you have the monitors there and the last thing you want is for nurses or other physicians to say, well, I don't even know what that thing is. Well, it doesn't get turned on all the time. And that's a big problem. So certainly our system administrators helped with that. But one of the things that we do routinely on our rounds is we educate. And being in an academic institution, we're teaching our interns and residents and students and our nurses. So it's commonplace for us to go to the patient to show everybody a salient clinical exam feature, to bring up a head imaging study of a CT or MRI, and make sure that the bedside nurse sees that subdural hematoma or that intracerebral hemorrhage and knows what they're looking at. And so it was pretty natural to start to do that with the advanced informatics information, where we could go back and say, oh, you told me that the ICP was elevated at 2 o'clock in the morning. Let's go back and look at the trends and see what happened. And then right in front of our eyes, we say, well, look at that right before the ICP went up, blood pressure went down. That's probably a sign of a patient that is autoregulating but had vasodilatation due to hypotension. And it's just visually apparent to folks. And we do that routinely at the bedside so that our nurses now start to use that on their own. They get used to it, and it's something that's accessible to them and doesn't seem mysterious or difficult to use.
Yeah, and I was amazed at, we did a webinar, with Deb and Lawrence, and it was on something that I didn't even realize you could use this monitor for. It was on managing blood pressure for spinal cord injury patients, and that was a real eye opener for me. And you guys are really pushing the envelope and in the use of the product, so it's amazing. I don't know if you have any comments on that.
Well, I think it's about access to information, and as I said, I've looked up one of my patients here to see how they're doing. So being able to have access to the information, utilize it, and feel like it's not scary to go up to the monitor and press the buttons and take a look. Because the questions about overnight trends or relationship between different parameters, they've been there all along. And I think all of us have that everywhere we are. But we're so used to not having access to the information that folks kind of have to get used to having access to the information and then using it on a regular basis. And we found the more our bedside nurses and other clinicians use it. I say play with it, but they're not really playing with it. They're actively looking at the data. Then the more they do it. The more they do it, the more they are comfortable doing it, and the more they find value in it.
Yeah, I think, and Lawrence has just suggested using this to look at shivering and monitor that, see if they could get some metrics so that they can monitor that while they're doing cooling. And so we're excited about working with your group now and in the future, and I think we'll see a lot more things come out of it. Any comments on where you want to take this program?
Well, I think that one of the things that you and I have spoken about, and this has really come from our bedside nurses, is they're very interested in how to look at the data in a user-friendly way. And when we look at the data on CNS Monitor or CNS Reader, we as clinicians are looking at it in a certain user interface that can be intuitive, but sometimes it's not. Going to the end user and say, how would you like to look at this information? So the concept of pie charts or histograms or heat maps or things like that might be simple shortcuts where bedside nurses can utilize that information in a way that makes sense to them rather than us telling them how they should be looking at it, I think is really important. And once again, that helps them engage with the product. So I may be interested in looking at this for dynamic Bayesian network predictive models. The bedside nurse may be interested in looking at it for what was the fever burden for the last 24 hours, or how often during her shift was the ICP elevated above our threshold that we chose, perhaps 20 millimeters of mercury. So the data is all there, and the visualization is going to be a great opportunity in the future.
Yeah, and we look forward to working with you. And UCSF also has probably one of the top nursing schools in the country, and maybe we can get this worked into their program. I think that would be an interesting thing, too. So, well, thank you very much for joining this podcast, and we'll look forward to working with you more.
Absolutely. Thanks a lot.
Thanks, Claude. So thanks for listening to this week's podcast. If you enjoy these interviews, please take a moment to rate and review this show on your podcast app of choice. Subscribe to Dick Moberg's Neural Network to receive notifications when future installments are available. Thanks for tuning in, and we hope you'll join us again soon.